So what are the options? When statin therapy is inadequate, you cannot get to the goal of less than 70, let's say, in a patient, or more than 50% reduction from baseline. What are the other options? Or somebody who has total statin intolerance. That is a kind of difficult thing to resolve, because many patients who are apparently intolerant to one statin will respond to another statin. So the current understanding is one should try at least 3 different statins before calling somebody as a totally statin intolerant person. Because all said and done, even low dose statin therapy is very important to continue before you add other drugs. What are the non-statin LDL cholesterol lowering drugs? But for years, we have known drugs that reduce cholesterol absorption. Some of you in the audience are probably too young to remember that before statins came out, we used to have a drug called bile acid sequestrant, and they still exist. These are drugs like cholecyvalum, cholestyramine, cholestyramine. They go into the gut and they bind the bile acid, and thereby they prevent cholesterol absorption. So that's an alternative. Adding it to low-dose statin therapy is like tripling the dose of statin therapy by way of much more cholesterol reduction. They are not very effective in lowering cholesterol, but they lower LDL by 15 to 25%, which is highly significant if you add it to low-dose statin therapy. Keep in mind that triglycerides may rise on bile acid sequestrant. So if you have triglyceride level above 300, 350, it's a relative contraindication to use bile acid sequestrant. Another choice is a cholesterol transport inhibitor at the level of the gut. It's a drug called ezetimibe, probably available in Cameroon. It's now generic, so the cost is much less than what it used to be. And it actually binds to the intestinal cholesterol transporter, which is a different mechanism than the bile acid sequestrant. This drug is very easy to take, as opposed to bile acid sequestrant, which have side effects at the level of the gut, about 20% rate of constipation with bile acid sequestrant, but ezetimibe is really quite effective and quite safe without any side effects. It also lowers LDL cholesterol quite effectively, and by adding it to low-dose statin, it's like going from atorvastatin 10 to atorvastatin 80 because you get additional 15 to 20% reduction. The main question that was bothering everybody was the long-term trials to show that they also reduce cardiovascular events, not just lower cholesterol. That's an important issue. Before I get into that, I just want to mention that there are 2 other drugs worth keeping in mind. One is niacin, which has been known for a long time as a drug that lowers both cholesterol and triglyceride. But there has never been enough data in the past that it actually lowers cardiovascular mortality. So this is an agent of the last resort. And even fibrates, which actually are even more modest in their cholesterol reduction, which are mainly suited to lower triglyceride, is very, very minimally used in lowering LDL cholesterol because of their very modest effect on lowering LDL. So there was a trial called Improve It trial, which was published a couple of years ago, which was a trial carried out in patients with acute coronary syndrome, very large study, who were already on statin, simvastatin 40 milligram, and then were randomized to receive either simvastatin alone or simvastatin plus ezetimibe. It's a very important trial because this is the first study with a non-statin drug that by adding a non-statin, ezetimibe, in people who are already on very good control, LDL was 70, it was lowered to 54 over the course of 5 years. And you can see on the bottom line, there was a modest but significant reduction in cardiovascular endpoints, about 6 to 7% reduction in a major cardiovascular endpoint, which was statistically significant. So one of the preferred drugs these days that is being used in people who cannot get to goal with statin or who cannot tolerate statin in high dose is to add ezetimibe. And this has now become part of many guidelines, both American Diabetes Association as well as American College of Cardiology in the past year or so. There are other novel LDL-lowering agents that I won't spend much time on, except for the last one here. The first one is the antisense ApoB synthesis inhibitor, which is very expensive and very difficult to use, an injectable drug, and has a lot of side effects. So let's not discuss that right now. MTP1 inhibitor is similar new agent, which blocks the assembly of all ApoB lipoproteins, and again is very expensive, has a lot of side effects. The last one, actually I mentioned because this agent, when it becomes cheaper, it's also expensive, but will become one of the most suitable drugs to add to statin or even to start by itself if statin cannot be used at all. It's a class of drugs called PCSK9 inhibitors. So let me say a word about what PCSK9 inhibitors are and how they work. So PCSK9 is a protease enzyme, and it is secreted by the liver. Now remember how the LDL receptor works. When LDL particle gets into the liver and other tissues, it gets into the liver by binding to a receptor. It's called LDL receptor. You all know that. Okay, LDL receptor was discovered many years ago, and that was the basis before the statins were discovered. So when LDL particle enters the liver along with LDL receptor, the LDL receptor supposed to recycle to pick up more LDL particles. But what happens is that while the LDL particle is degraded in the liver, in the lysosomes, the LDL receptor also gets partly degraded. And this happens because this enzyme PCSK9, which is made by the liver, also gets into this LDL particle LDL receptor complex. So it kind of basically shuttles as a kind of takes a free ride along with the LDL particle LDL receptor, and it interferes with the LDL receptor recycling in such a way that it also breaks down the LDL receptor itself. So now you're losing not only LDL particle, but also losing LDL receptor. Very little LDL receptor comes back for recycling. So the concept behind PCSK9 inhibitors is that since this is a secreted protein, PCSK9, you develop an antibody against this PCSK9 molecule. And once you have this antibody, it blocks the LDL receptor for binding to the PCSK9, because PCSK9 is now being bound by this antibody. So more of the LDL receptor now is available to shuttle back outside and recycle and bind more LDL particles. So in other words, it's like saying that you're twice as many LDL receptors available once you have PCSK receptor antibody. Let me show you an example. Early on, when these trials were done, since it's an antibody, it has to be given by an injection. It has a long half-life, about 2 weeks, and depending on the dose, you can sometimes give it every 4 weeks. But in one of the earlier studies, there were some patients who had familial hypercholesterolemia, very high cholesterol. LDL was still 160 to 170 after they had been on statin and in many cases also on ezetimibe. When given this agent every 2 weeks or every 4 weeks, you can see the LDL receptor dropped, LDL cholesterol dropped by another 60% on top of what was achieved on statin and ezetimibe therapy. So you can start with LDL of, let's say, 160 in this case, and it drops down to about 80, which is not possible with any dose of statin therapy, even in patients who have very high LDL cholesterol but have very high LDL cholesterol at baseline due to familial hypercholesterolemia. These people normally have baseline of about 200 and above. So this concept was then taken into clinic, and clinical trials have been initiated. 2 of these agents are in clinical trials, one of which was just published a few months ago, actually this year in June, and presented earlier and published at the same time. Let me get back to my show here. So this is the trial. Now, this has been available, these 2 drugs have been available in the US for the past 2 years because they're so effective in the patients that I mentioned, although they are quite expensive. And there's a lot of push now on the drug companies that make these agents to make it cheaper for people who cannot tolerate high-dose statin. So the first trial called the FOURIER trial, was published in New England Journal a few months ago, called the trial with evolocumab. The other drug is called alirocumab. I'll just show you briefly what this trial showed. This was a big trial, almost 27,000 patients who had cardiovascular disease at baseline, who were all given high-dose statin in most cases, and in the rest of them, they were given moderate dose with ezetimibe. In other words, they had a very good LDL cholesterol at baseline of about 80 to 90 milligram percent. And you can see here that over the course of about 26 months on an average, they had a reduction in the cardiovascular endpoints of about 15%. If you look at the more traditional endpoint of total MI, total mortality, non-fatal MI, and stroke, that was reduced by 20% as shown here. Cardiovascular death, myocardial infarction, and stroke, the traditional endpoint. So that's a very significant reduction on top of statin therapy by lowering the LDL. Actually, the mean LDL in this study went down to about 30 milligram percent. And you might ask, is it safe? And they did a fair number of battery of neurocognitive tests, and they showed that even people whose LDL cholesterol went down to less than 25, there was no effect on neurocognition. But keep in mind that this is a 26-month trial. It may not be long enough period, and we still need to ask the question, how low is safe for people who want to get their LDL cholesterol to a much lower range in order to reduce further events. So the bottom line is that more and more evidence in the past few years that even LDL cholesterol of less than 70 may not be enough for future cardiovascular events. That one can get, if one can get lower LDL, lower and lower, as long as it is safe and patient has no side effect, then that might be helpful, as proven by this trial. By the way, I should mention that in this trial, unlike statins, there were no effects on myalgia. Okay, same number of people in both groups who had some muscle pain, no increase with evolocumab, and there was no increased incidence of diabetes thus far. Now, what about the rest of the lipid picture that we often see in our patients? Patients who have mixed dyslipidemia, and how to assess and treat such patients. So, first of all, I want to remind you that more than 40% of patients who have coronary artery disease and are very high risk, they continue to have additional events even after they've been treated with statin. Going back to the point that so far, part of the reason is that we're getting patients down to only less than 100 or less than 70, and we're finding that we thought that that was enough LDL cholesterol reduction. But in new analysis that have been compiled from the statin trials, it's been shown that even if your LDL cholesterol goes down to below 70, you still have 30 to 40% recurrent events. And the second question is how to approach patients with high triglycerides and low HDL cholesterol. Because for years we have known that these particles may also be contributing to cardiovascular disease based on epidemiological studies. But there was no good randomized clinical trial to prove whether or not lowering triglyceride and raising HDL, something we always believed as a leap of faith, will be effective if you also have somebody on statin therapy already and getting the LDL cholesterol lower and lower. So that kind of trial thus far was not done until very recently, and I'll show you what that showed. Before we get into that, what are the recommendations currently for non-HDL cholesterol? Because patients with high triglycerides should actually have non-HDL cholesterol calculated as a better way to assess their risk. So it is recommended for the past many years that people who have triglyceride 200 to 500 calculate their non-HDL cholesterol and intensify statin therapy if the LDL cholesterol is in goal, but non-HDL cholesterol is still elevated. Why is that important? Because these patients have non-HDL cholesterol contributed by the triglyceride cholesterol, VLDL cholesterol, and that's also atherogenic. But in people who have very high triglyceride over 500, one should think about treating them with a drug therapy if needed, but first we should intensify lifestyle because we know that triglycerides are highly dependent on weight reduction, exercise, glycemic control if you have diabetes, and avoiding excessive alcohol. And if the triglyceride remains above 500, one should use either a fibrate like fenofibrate or fish oil, omega-3 fatty acids in high dose, because these patients are at high risk for pancreatitis, and not so much for cardiovascular disease, but for acute pancreatitis. And finally, once the LDL cholesterol, once the triglyceride comes down below 500, then you should reassess their LDL cholesterol and non-HDL cholesterol and treat them in this category by intensifying statin therapy if their non-HDL is still elevated. I hope that I made that point clear, because people with high triglyceride often have LDL cholesterol in goal, but if the triglyceride is contributing to the non-HDL cholesterol, non-HDL is still high, the ideal therapy is to intensify statin therapy before you think about fibrates.